But now this patient has reached a critical point. He is both resistant to second generation AR targeted drugs, and he's also essentially resistant to docetaxel chemotherapy, or let's just say that he has disease progression despite docetaxel chemotherapy. Now, there are a few options of FDA-approved drugs for patients with CRPC that we have not talked about. We've not talked about radium-223, and we've not talked about sipuleucel T. And one might wonder if those are reasonable options for this patient. My approach and my opinion based on the data is that this is not a patient who would be appropriate for really either one of those treatments. I do use sipuleucel T, but I don't use it in the majority of my patients, and I don't use it in patients who have symptomatic CRPC, and I don't use it in patients with rapidly progressing visceral metastases. The reason for that is sipuleucel T probably exerts some effect on survival and disease progression when it's given earlier in the clinical course, perhaps with a lower volume of disease. So if I were going to use sipuleucel T in this patient, I might go back in time to when his PSA was 10, and he was beginning to progress after the docetaxel. In that setting, he's likely to do just fine from a symptom perspective for a long time. Recall that sipuleucel T does not induce a remission. It does not take PSA down, but in a minority of patients, and it's not really known to reverse symptoms or shrink tumors. It simply slows the progression of the disease. That may be of significant benefit for some patients, and when we looked at it in a phase 3 study across a whole population of prostate cancer patients, we demonstrated that actually it does exert a survival benefit. So that's important, but at this point, with the liver mets, the new bony lesions, and the rising PSA, this is not really a situation where sipuleucel T is going to be the answer. Similarly, radium-223 is a treatment that is really designed for bone disease and is really approved for patients with symptomatic bony disease. Now, he is not at this point complaining of a significant amount of new pain, but we are seeing new bony lesions develop, and he's also got the liver mets. So radium is a bone-targeted therapy that is not going to have any effect on those liver metastases. And those liver metastases may be the biological process that is most likely to lead to lethality for this patient. So we really need to address those liver metastases, and we can't do that with radium. And we're not going to see much benefit from sipuleucel T because that window closed about a year ago for this patient. So that leaves us with second-line chemotherapy. This is a patient with docetaxel resistance, who now may benefit from cabazitaxel. And cabazitaxel is a therapy that has regulatory approval for exactly this indication for patients who have already received docetaxel chemotherapy who are developing disease progression. So let's go back and think about some of the cases here that why we might want to choose docetaxel in this setting. So what are the factors that we want to consider for this patient in terms of his side effect profile, quality of life, etc. Now, this patient, if we've been doing the math correctly, he's now 3 years on from the time of discontinuation. 3 years on from the time of diagnosis of prostate cancer. So he's probably about 70 years old. We don't have any additional history about a cardiac history or stroke or diabetes or anything like that that has taken a hold of him that might impact our choice of subsequent therapy. So I think that that's good. It leaves a blank slate for us in terms of talking about the side effects of treatment. So here we are in the setting of abiraterone resistance. And per our case, he's still on the abiraterone, but he's developing disease progression. So one question is, should we add chemotherapy to the abiraterone, and is that of really any benefit? And the truth is there is some emerging benefit that the combination is feasible. There was a study called ABI-CABAZI where cabazitaxel and abiraterone were completed. And there is some ongoing work looking at docetaxel abiraterone combinations. And I think it's fair to say that that remains an interesting question, but I wouldn't say that we have level 1 evidence at this time to say that both therapies should be continued. And so for the time being, I consider this to be abiraterone-resistant disease and not one where I think I still need that suppression of the androgen production from the abiraterone. I hope I'm proven wrong in that maybe combination approaches can be demonstrated to be superior to a single agent. But in this setting, we're most likely well served by simply discontinuing the abiraterone, continuing the prednisone, and adding in cabazitaxel.